warm welcome to today's session, which is organized by IMA Maharashtra Spiritual Committee and hosted by UMANG. Myself, Dr. Prachi Borkhe, and I, along with Dr. Shrutika Kotkunde, feel privileged to serve as your moderators for today's session. Before we get started, a special welcome to Dr. Santosh Kadam Sir, Secretary in Maharashtra State. It's an honor to be graced by your presence, sir. Without further delay, I hand it over to Dr. Shrutika ma'am. Over to you, ma'am.
Yeah, thank you, Prachi. Welcome everyone to the 24th session of UMANG, the brainchild of Dr. Gauri Kuril. When we were in the aftermath of COVID and we all were trying to get to grips with what was happening around us, a lot of us doctors were also dealing with the emotional aftermath at the receiving end. And this triggered Gauri, and Gauri is my classmate from MBBS, and some like-minded doctors to come together and form a forum of doctors, for doctors, by doctors, and try to address emotional health issues for doctors. So that's how UMANG started. And from a modest beginning over the last 2 years, we have covered lots of different topics like burnout or money matters, finding balance in life. And we have gone from strength to strength. And today's topic, communication skills, is an extremely important topic, as we all are aware in our practice. Communication is key in our practice, whether it be surgery, medicine, or any other branch. So today we have some very esteemed speakers amongst us, and it gives me great honor to introduce them to you. I start with Dr. Professor Gaurdas Chaudhuri. He is Chairman, Department of Gastrointestinal and Hepatobiliary Sciences, Fortis Memorial Research Institute, FMRI. And he has worked at SGPG IMS for 25 years and 10 years as Head of Department of Gastroenterology. He is WHO Fellow in Health Promotion from University of Sydney. He writes a weekly health column, Health Adda, for the last 13 years, and he has nearly 240 publications and 12 books to his name. We're really honored to have you on our dais.
Thank you so much.
Our next speaker, Dr. Sita Raju. She is ex-associate professor and assistant honorary physician, Rajiv Gandhi Medical College, Thane. She is proprietor and consulting physician at Dr. Raju's Hospital and Param Hospital and ICU Thane. She is also honorary physician, Jupiter Hospital, Thane. She is also faculty in state and national conferences at MAPCON, APICON, and RSSDI. She is faculty for Public Health Foundation of India and for the CCEDM. She has received awards for outstanding service from the Indian Academy of Diabetes, March 2019. I hand over to Prachi to introduce our third speaker.
Our third speaker is Dr. Ishaq Khatib, sir. Sir is a senior surgeon at Chipur. He has 30 years of clinical experience and 10 years as head of multi-specialty hospital. He is the chairman of Govalkot Education Society and ex-treasurer of IMA Chipur, and had been associated with SAISI, Jaslok, and HN Hospital. Welcome, sir. So let's start with our panel discussion today. My first question is for Sita Raj ma'am. Ma'am, what are the basics of establishing a good rapport?
Good evening, everybody. I'm very happy to be here as a part of this very interesting topic of communication skills. I thank UMANG and Gauri for having given me this opportunity to express my thoughts. Now, the most important aspect to develop a patient rapport is to develop the art of listening. You need to listen to your patients, and half your work is done. The science of medicine we learn in medical school, and the art of medicine we develop over the years with practice. And building a good rapport is the heart and the art of medicine. We need to allow patients to share their thoughts with us so that we can read their minds. We have to understand their body language and have a non-judgmental attitude. For example, if a patient is waiting for too long in the OPD and he's already disgusted when he's walking into your room, and then you sense his body language and you mellow him down and win his trust. Believe me, trust changes everything.
Thank you, ma'am. Coming to our next question. This question is for Dr. Chaudhary, sir. Sir, how to interpret verbal and non-verbal cues of patient and use them in effective communication?
So, thanks to UMANG, by the way, for the invitation. It's a pleasure. So, what I've started doing is that when a patient enters my room, he has to feel that you are concerned about him, you are a bit respectful towards him, and whether you're welcoming him or not. And I can tell you from my experience, both in the government sector, where I have spent about 35 years, and 10 years in the private sector, and some in the international arena, that many of our initial approaches to the patient need to be better, and one learns the hard way. For example, I've seen that even if it is a person who comes from a village and is very rustic, I usually often stand up when he enters the room. And then I greet him with something which is familiar. So if it's Hindi, I would say Namaste, kya haal hai? If it is one of my Muslim patients, I would say Adab, and things like that. But, that makes them feel comfortable. And I think that I usually stand up and offer them the seat in front of me. Now, this is a typical non-verbal communication, offering the seat. That's, the chair. Actually, in most situations, I've seen people are usually busy on the computer or they're on the cell phone, and then they expect the patient to come and take the seat on their own. Some of them are a bit hesitant. And I think that that is one of the, shall we say, not too comfortable starting points in building a rapport. So I think Madam who just spoke in front before me, I fully agree with her. How to start the whole process of rapport building going is by a little bit of a mutual respect and by making the person comfortable. I was very happy that she mentioned about the delay and this long wait outside the chamber. It happens, and I know that some of them are literally abusing me probably outside. But when they come in, I often what I do is I just tell them, I think you must have been waiting long. I'm indeed so sorry it took me so long to see you, and my apologies. As soon as I say that, I know they have quietened down. So these small little tricks make a lot of difference. And without meaning to sound offensive, I must say that Indians are not very good at being a little soft and modest. I mean, I might say that the Americans are more formal and, it's more politeness rather than empathy. But we go to the other extreme. We may have empathy, but we are a little rough with our words and manners. So I remember when I have often visited other countries, quite a few of them, I was in fact in those days very surprised 30 years ago that they would get up, stand, shake their hand and say, how are you, Mrs. Jones? It's a pleasure to see you. It may be artificial, but I tell you, it makes a difference. Whereas here, to the other extreme, I would have seen many of my just sitting there, not bothering, no smile on his face, not even asking the name of the person, where are you coming from? And straight away asking, problem kya hai batao? That is not rapport building. You have to first give that person a little dignity that he or she is a person, you are interested in him, and that is what rapport building is all about. So I think that if you get your things started well, it usually ends well. That's my observation. If there are any
These are
questions,
very
I'll take it, but
practical
I'll
tips,
do
sir.
it.
Thank you, sir. My next question is to Ishaq, sir. Sir, how should one should open a conversation, like check how they understand you, how to sum up to satisfaction of both patient parties?
Yeah.
How to
Thank you
open
very
a
much.
conversation?
Yes, yes. Thank you very much for the UMANG to just, include me, such a small place surgeon, into this conversation. Thank you very much for the whole of the team, and good evening, everybody. I think the question was, most of the part of this question was explained by Chaudhary sir as well as ma'am. And it is almost there that, first is the greeting. As soon as the patient comes, sir said that, you have to get up, you have to just tell them that, to just sit there. And the first thing is you have to call them by the name. They are not the things, they are not the articles, they are the human beings. So it is better to always call them by the name. Usually it is better to call them by the last name and then just ask them to sit there and then make them comfortable. They should feel that, they are with somebody who they know since many, many days or many, many months. And then you can ask them after a greeting, then you should ask them, okay, what is the problem? What brought you over here? So this is the honest question. And then afterwards, you can, listen properly. As madam said, that listening is really a good art, which every physician and surgeon should be expert in it. The next thing is, whenever he's coming for the follow-up, at that time also there are so many things. First thing is, we have to ask about the response of the treatment, last treatment. How was the response? Many of our colleagues, whenever they say, I didn't get relief from the last medicine, then they become a little bit nervous and they just say, why this is not, you are not taken properly. Just don't deny the fact that, there was less response and they are not happy with your response. So you have to agree with that. And then you just ask further questions and try to find out what are the problems with them. Then another thing is, you have to understand, you shouldn't come to the conclusion suddenly that they have not taken proper treatment or something like that. And you should make them feel that that what the feeling of their suffering is. If you just talk with them so nicely that they feel that you are concerned with them, I think that is the point where exactly those people will start talking openly. And this is the way you should start your conversation. Don't ask anything about the previous doctors. Don't comment anything on the previous doctors' ethics and what they have given, whether that is correct or wrong. Many of the colleagues I have seen in the rural area especially, that if the patient comes after a long time and in between he goes to some other surgeon or other doctor, at that time they become a little bit panic and they say, why did you go there? And then I was here only. If the patient says that, no, you were not here. No, on which date you did? Don't inquire anything. Just be comfortable, don't ask them anything that will just, make them a little bit nervous or something like that. So this is the way you should start your conversation and then try to find out the other problems. This is my way of starting the conversation. Yeah.
Thank you, sir.
Very important points to note, sir. Shrutika ma'am,
Yeah.
over to you.
Yeah. Truly said, sir. Madam, how would you say that one balances empathy and professionalism? Because we want to sound sensitive, but at the same time, we don't want to sound very emotional. So how do you strike a balance with your patient?
I think the best way is to be assertive without being overbearing. If we are not assertive, they may take us for granted. Second thing, I think you have to address all their fears. However silly it may sound to us, it's a fear for them. So reassure them, be empathetic, be clear and compassionate with them, and be truthful to them. Be truthful about the disease, about the treatment. And we have to respect them. Once they see that we are respecting their fears, they take on to us. They are more at peace and at comfort with us. And at the same time, patients are opportunists. So we have to draw a fine line and draw a line to their unrealistic expectations. Sometimes they expect the world, and we must at the outset tell them that some expectations of theirs may be unrealistic. So we have to make them aware of it. And we have to learn to say no tactfully, but assertively. Many of us doctors, I'm including myself, don't say no when we feel we have to say no. That's also an art to be learned with patients so that they respect us also. Secondly, your tone of your voice, your modulation, your pitch should not send a signal to them that you're angry, disgusted, in a hurry. This is all body language, what doctor spoke of, non-verbal communication. So this sends a signal to them that, I mean, probably I'm not in the right place. So these are the precautions that you need to take.
Thank you, madam. Chaudhary sir, how would we handle an angry patient? Because most of us during our practice, we will be faced with a situation where either we have to face an angry patient or relative, or sometimes even a mob. How does one handle one's own anxiety and get the right message?
So I'll bifurcate the question into two. One is how to deal with an angry patient or a relative. And the other is how to deal with a mob, angry mob. You know why they're different? Is because dealing with an angry patient is a common thing. It happens. And, obviously there will be frustration if the patient has died or they're not responding. They're spending a lot of money. They have a right to feel angry. And often, if anything goes wrong, they would like to think that either you or the hospital or somebody is accountable, and that's why the anger builds up. The common mistake that I have seen people do is to deal with an angry patient by trying to give a long logical explanation as to why he should not be angry. I mean, honestly speaking, that's the biggest stupidity that I have seen doctors do, including most of my colleagues. Remember that anger is actually an emotion, and it's not a logical emotion. Most emotions are not logical. So it is a strong emotional response. So that is hardly the time that you call the person and then you start giving a long explanation as to where do you think the surgery went wrong and the perforation could have occurred, or why the gas is not moving down. Ridiculous. He's not in a receptive mood to listen to the logical explanation. So doctors often use logic when the person is emotional, and that should not happen. So if you sense that the person is angry, or if the person is sad, see, these are emotions, and the best way to deal with emotion is a very simple thing, that is to agree with that emotion. So if a person is angry and is shouting in the corridor, I would actually just go to him and say that I can quite understand that how angry you must be feeling, because I mean, it must have really, the whole situation would have made you very angry. If I were you, possibly I would also feel the same. As soon as you say that, that is, you have given a sanction to his emotion, he will start quietening down, and then he will probably be receptive to your logical explanation. But if you try to meet the anger with logic, it just doesn't match. So this, I would say, is the most important thing. I was surprised. I was giving a talk in Guwahati just last month, and this was my talk, how to deal with an angry patient. I was surprised that, of the top 20 top people, surgeons and physicians, senior people, they all agreed with me, whereas the young people didn't seem to actually think that that could be a worthwhile approach, because young people are all the time trying to give a justification or an explanation in biomedical terms, and biomedical terms don't work with an angry patient. Okay, so this is the gist of it. Why I distinguished a mob from an angry patient is because, the mob mentality is a little difficult. It is not about the individual's emotion. It is when 3 or 4 or 10 people get together and then they have a lot of synchrony and resonance of their anger, then often it leads to potential violence, and they can actually get into attacking mode, I mean, either doing harm to the hospital or to the individual. So if you see a mob, I don't think that that is a wise time to go into the mob and try to calm them down, because although you might be talking to 2 or 3 people who are possibly closer to you, there are others who might be mischief mongers or a little volatile, but on the fringe, and they might either throw a stone or use a stick or something like that. So when I see a mob, I usually would call two of them inside and try my method. But at the same time, I would send a signal to my secretary or others to also call the security, not that they have to come and actively interfere, but their presence is required. You know, it is so often that has happened. I think the last to last episode, it happened in, I think in Maharashtra, if I'm not mistaken. A young doctor who was an orthopedician was beaten up badly, and he was the only scapegoat they found. We had one gastroenterologist in Allahabad who was beaten up, and you know that video went viral. And again, I'm not here to be judgmental as to whether the doctor was at fault or not. That's not the issue. But the issue is that a mob mentality is a difficult mentality to be able to be handled by one person. Unless you're an extraordinary person, like say, for example, one of our Augustus Caesar or somebody like that, you know, who can actually quell a mob with his tremendous oratorial skills and so on and so forth. But usually that is a bit of a
It
Have
rings
I
true, sir,
answered you or any
because
question?
because hospital is a lot of emotions are being played out in the hospital or nursing home.
Absolutely,
So
absolutely. So that
yeah,
is the reason why
we need to
you
take
have
care.
to address the emotions. If it is 2 or 3 people and they look okay, you know, it is good to have their emotions sanctified. You know, empathy basically means that, you know, basically it only means that you are sending the
Acknowledge
signal,
them.
I understand
Yeah.
your feeling, and that is an acknowledgement of your feeling. That is all that empathy is all about. Empathy is
Well
not the
said,
same
sir.
as sympathy or kindness or trying to share their emotion. It is understanding their emotion, not really sharing to the extent that they are crying, I have to cry. That doesn't work. I mean, if we had to do that, we would be crying all day. But the signal has to go that, yeah, we do understand your emotion. We share that, you know, this is a very genuine emotion. I understand how terrible you must be feeling. And then once you are in that page, then you take them on to what can be done or what cannot be done, or how to accept something, and so on and so forth. So that is the only way forward when it comes to a small group, even a family. Mob, you know, there have been umpteen situations you would have seen in the papers or in the TV of vandalism and people coming and breaking glass and creating mischief and actually mainly assaulting doctors, physical violence. So that becomes a problem if there is a mob out there. And there, you know, logic doesn't work, nor does any of your, because, you know, it's say 50 people against one. So that one person is obviously not going to stand a chance against a
Right.
very rowdy kind of a mob.
Yeah. So we need to be a bit discreet when there's a mob. But yeah, thank you, sir.
Definitely. So I
Yeah.
think that your
Okay, sir.
personal
Yeah.
safety is also important when it's a rowdy mob.
Yeah.
Because, you know, I think that, you know, I can tell you that umpteen situations I have come to realize. So there is a fellow who's admitted, and death is obviously not an acceptable alternative to many people. And, you know, they would have the whole village or the community or, you know, people coming around. And the
Yes.
fact that the person was very sick and died and not much could be done, it's not acceptable. So if a person dies, so that whole 50 to 100 people would be converted into a stone throwing or a lathi charging mob, and that's a very sad situation. I don't think that it's fair to even expect a junior doctor to be able to manage that.
So I say that when there's a mob, you try to talk to 1 or 2 people, but do involve the
I'll call
security
2 or 3
and try
people.
to be safe
Yeah,
than sorry. Yeah.
I'll
Moving
call 2 or
swiftly to
3
the
people.
third. Yeah.
Yeah, so
Yeah.
that people feel that, okay, I'm
Yeah.
not shying away from them or ignoring them,
Yeah.
but the
Yeah.
others I would ask them to be outside, and in the meantime I would actually ask for somebody to make arrangements for
Yeah.
security, because I can understand things might be taking a different shape.
Thank you, sir. So Ishak, sir, how should one persuade a patient or a relative about what much needed treatment? Because often we are faced with a situation
Yeah.
where we want them to agree on it, but how to be gentle and
Yeah.
go about
First
doing
of all, you know, whenever a patient has to be admitted or persuaded for a surgery or a procedure, at that time, what I feel is first, the disease process should be properly explained in their own language in a very simple manner. Sometimes we use some medical words which they don't understand, and they consider according to their own knowledge that how it is. So it becomes a problem. So first of all, try to tell them what the disease is, and then just tell them what are the different modalities of the treatment, what are the different procedures we can do it, why the surgery or the admission is necessary. If we will not do the surgery, what will happen, what will be the natural course, and if we do the surgery, then what are the possible results. So we have to explain this. What I personally do is, whenever, being a surgeon, whenever I want to take the patient for the surgery, I just make a simple diagrams and just try to tell them in their own language that what exactly has happened, where exactly if the intestine is necrosed or something like that, how I'm going to just cut it and do it. So by just explaining all that on the sketch, or sometimes you can use the visual slides also, they understand very well. And then another thing is, you have to be very, very clear about the financial aspects of the surgeries. You should tell about the complications. You should tell what are the modalities which are available at your hospital, which are not available at your hospital. Even if the surgeries which are not available at our hospital, we have to tell them, you have to just give them the idea that what exactly will be the cost of that surgery. And then you have to tell, okay, this surgery, if you do it here, then this is the financial background that you have to spend this much money. And another thing is, this procedure is good, and you can just tell that, I can give my 100% and I will just make sure that this surgery, we will do it here better. And this way we can convince the patient, and you should give a sufficient time to the patient that whatever their queries are, whatever their feelings are, they should just come out and they should speak in front of you, and you should satisfy them to what exactly you want to do it. So this is the way. You should not force any operation, any surgeries, because I had seen in my 30 years of experience, if at all, if somebody is just forcing anybody for some surgery or something will go wrong and some complications will occur, and then we'll end up in a trouble. So it is better, convince them, tell them everything about the complications also, tell them if at all there is a better treatment available at other place also. This is the best way. This will always is secure, and it will help you for the prognosis of the patient. This is the way I do it usually. Okay.
Thank you. Dr. Raju, any comments? Your comments on this?
Sir has said it all, but as a physician, there may be more than one option. So we give all the options to the patients and put the ball in their court. You tell them to take a family decision as to which path they need to follow. Very often, patients throw the question back at you and say, "Aapki maa tha to kya karte the?" So then be truthful and tell them what path you would have followed. At the same time, we need to tell them that no treatment option is 100% successful. Because when you give them the option, they feel that this is a road to success. So we have to tactfully tell them that nothing is 100% successful. Whenever possible, give statistics to help them make a decision. A simple example, patient advised an angiography. The patient is reluctant. The relatives want to see results. And then they ultimately say, okay, we'll do the angiography and see. Then we explain to them there's no point in finding out how many blocks and sitting over the blocks. If you're going to take action, go ahead with the angiography. This is just an example. So you put the decision in the patient's hands so that you're comfortable.
Chaudhary, what would you say?
No, I
For
would agree with.
persuading, yeah.
I would agree with what Madam said. See, actually, I think it depends on what phase of life you are. Let me tell you what I mean. A lot of young people, they are a little bit anxious that the patient should be with them and they should do the procedure rather than giving them time to think. Because if they do, they would go to another doctor who might then do the procedure and the bird goes out of my hand. That feeling, I mean, let's accept it. That's very much a phenomenon. At my phase of life, it doesn't bother me. So that's the reason I'm not interested. But actually, if I'm a little dispassionate and not appearing to be very convincing in that sense, quote unquote, convincing to get it done, I find that they actually come back, and they come back with a lot more, shall we say, commitment, because I've been fairly honest and straightforward with them. But unfortunately, you have to be a little mentally prepared that, look, there will be people running to and fro. Some will come to you, they will go to another doctor, they will not come back to you again, and so on. So I think that we should also not be very possessive about the fact that the patient should get it done by me. Doctors, unfortunately, have very big egos. And they often think that, look, I am the best, and why did he come to me and then go to somebody else? A little bit of being philosophical to accept that, look, there are others also here, they can also do a good job, and the patient may like that doctor's face and tone better than mine. That humility has to come. I mean, it should not be to drive home the point that the person should come and stick to me and get the procedure done. I have to be honest with the patient, empathetic with the patient, and then, if suppose he goes elsewhere, it's fine. I was very amused with that comment made by our surgeon colleague, when he so when somebody goes to another patient and then he comes back to me, I've seen a lot of doctors feeling very affronted. Maybe when I was young, even I used to feel affronted. I mean, I told you the best, and why did you go to somebody else? Now, what I do? I do the other way around. I said that, so did those medicines help you? So he said, no, not much. But I said, but the medicines that he gave were quite good. I'm surprised that it didn't. So I usually compliment the other fellow, who in a way would be my rival. But that sends a message across that I'm not actually trying to pull down my rival. I mean, as long as I think that what he did was right, like if I wrote a H2RA acid suppressant and he wrote a PPI, and I mean, it's fine. Yeah. I mean, learn to be graceful, to be able to give little bit of compliment to others who might be perceiving you as a rival, but I don't have to perceive them as a rival. I think that is how
Well
practice
said.
goes. Because ultimately, I'll tell you,
Yes.
the majority of practice, at least in my experience, and I can tell you that I have been through 3 hospitals and 2 private hospitals. I think that the majority of patients for me are not referrals from other doctors. I get quite a few referrals, but most of it is by word of mouth. And I think that if suppose you create a goodwill and you have a very good word of mouth phenomena going, that's your biggest asset. When it comes to your other doctors referring to you, there are many things involved, sometimes even economics. So that's why I stay completely away from all that. And I think my best, shall we say, best trump card is actually very satisfied patients.
Thank you, sir. Pearls of wisdom. Thank you, sir. Over to you, Prachi.
So as we discussed now, that communication with a relative in a situation is really very important, and it has its own role to play. Sita ma'am, what helps when talking to a relative of a patient, and what caution we should take?
I think we communicate to the patient what we think. Mark Twain had said very famously, if you speak the truth, you don't have to remember anything. It's only when you twist the facts, you forget what you have said. So when you are truthful to the patient, it's not an effort to remember anything. You start with the background information, because generally many relatives and suggesters come when the patient is becoming bad. So you tell them about the background disease. What were the options available? What was the condition when he first came to the hospital? You state the solutions that are possible, and some of these solutions may work, some may not work. Now here you have to be careful to edit also a little, because too much detail buries the core point, and then we keep going round in circles. So use simple language, be direct, and let it be a two-way conversation. Let them ask their questions, you answer. And at this time, like the other speakers suggested, you could give them a free hand to take a second opinion if they feel, or call any of their doctors and take a look at the patient. So you have to be communicative in such a way, your body language should suggest that you are comfortable treating the patient. Are they comfortable with you? You can judge by their body language.
Thank you, ma'am. Chaudhary sir, how to handle conflict with patient, relatives, and also with colleagues? What are the do's and don'ts?
Very difficult question. You know why? Because when you're talking about patients' relatives, sometimes it's a very mixed bag. And I must tell you, recently something happened. There was a 70-year-old gentleman admitted with me with acute pancreatitis, alcoholic, and one problem led on to another. He stayed in the ICU for close to 20 days and then he died. Now, what happened, I'll tell you. He had multiple other problems, so I'll cut a long story short. So after about 10 days to 2 weeks, we realized that he's not getting well. So we usually have something called a multidisciplinary approach. So we invite all the relatives to come. We have all the doctors on one side. So like a gastroenterologist, the critical care medicine chap, the surgeon, and infectious disease, and also 6 of us or 8 of us. And we put forward our case and we ask them whatever you want, you can ask. So we are very straightforward. Now, what we realized is that when things were not going too well, I was right from the beginning of the opinion that, look, modern medicine doesn't really have a treatment for acute pancreatitis. It can only give you supportive care, and the body has to fight. And if it has the energy and if the person has the willpower, he may come out. He's 70 years old. So the question is that I realized that within the family, there was a little bit of a polarized view. So there was the daughter and the daughter-in-law and few others who felt that, look, if we are only prolonging his suffering and he's not likely to recover, we shouldn't be going on putting him on intensive care. On intensive care, like say ventilation, dialysis, and so on and so forth. You are basically prolonging his life because he's not responding. Whereas one son, he was a very aggressive fellow. So he was of the opinion that we should do everything to the last penny. And there was a huge division within the family. And my secretary told me a few days ago that, sir, just outside your office, they were almost coming to fists, the two brothers, because one was having a view that we shouldn't just stretch his suffering too much and be realistic and accept, whereas the other was not. Now, they were fighting it out between themselves. These are difficult situations where, as a doctor, I can't take sides, in the sense that I have to tell them the facts, tell them the percentages and things like that, but I have to encourage them to take a decision. So suppose I say, no, let's give it up and let's actually have you sign something called non-escalation of therapy. He would interpret it that I'm giving up on his father and he wants me to fight. So it's very guarded. You have to tell the facts, but encourage the family to meet within themselves, find out who's the chief of the family, who are the people who are the key decision makers, and then we go ahead and try and see what happens. Ultimately, I'll tell you the interesting part of the story. This gentleman became so sick, he was virtually terminal, when suddenly the larger section of the family thought that his last wish was to go home and die rather than in a hospital. And then there was a huge scramble that, can you hasten up the process of Lama so that we want to take him home, because we just want him to go home and die. And I obviously played a very proactive role trying to get him home. And my concern throughout was, I went on asking the relatives, did he finally reach home alive before he died? And they said, yeah, he spent 90 minutes at home before he died. And they were very satisfied. So sometimes, it's not an easy decision dealing with patients of this type. There are conflicts within the family. There are economic costs. People come from different backgrounds. Some are from US, so they want the last bit to be done. Some are a little more mature Indians. So it's a complex group, and you have to navigate your way through. Sorry, I took a little time, but I must tell you that it's not easy. It's very complex situation.
Not easy. Yeah.
Not at all, sir. Thank you for the explanation. It's quite helpful for us to deal if there is any further situation come. Isaac, sir, what are the various communication styles is one style better than other, and how should one match with it with that of patient or relatives or with peers?
Yeah. Actually, there are so many literatures are available where different classifications are given. There are 5 types, 9 types, 7 types, whatever it is. But basically, there are 4 types of communications. One is passive communication, one is aggressive communication, passive aggressive communication, and assertive communication. And what I feel is none of this is good at all those situations. You have to just see the situation and accordingly see the situation, see the patient's relatives, what is their educational status, how understanding they are, and then you have to think about it. Because if you just go by the passive way of just communication, then what happens is you are just ignoring your rights, and because of that, usually those people will overcome you, and then there will be a very difficult situation. Sometimes it is good when there is a violence and all that. When there is a violence, chances of violence are there, and then you are just going through the passive situation communication, it is okay, but not all the time. The out of this, I think the best is the assertive communication. Assertive communication, what happens is you have to think about your rights as well as you have to think about the others. So it is a mutual respect. You are just, understanding each other and then taking the decisions. So most of the time, this assertive way of communication is better. And this depends on, the situation. When the mob is very anxious and all that at that time, and if they are just trying to overpowering you, you have to be a little bit adamant also. You have to be a little bit aggressive. So there, you cannot just, just hand over these things to them. Okay, whatever you say is right. You have to be a little bit confident about what you are saying. Your body language, what you are talking, that is more important. The way you are just expressing yourself, because most of the people, they just watch your body language, how you are talking, and what exactly the framing of the sentences are, and accordingly they will just jump on you. So it is very essential that you should understand the topic, understand the situation, and then only you should choose this. So no one, this thing is best, but still the assertive is always better because it is a mutual respect. This is the way I will just tell you. Yeah.
Understood, sir. Thank you, sir.
Okay.
Over to you, Shrutika, ma'am.
Yeah, I'm just a bit aware of the time. So, Prachi, I'm going to take your questions and you can take mine, the last ones.
Okay, ma'am.
Sita ma'am, how would you say one should seek feedback on one's own communication style, looking for blind spot in our own communication styles? What would you say? Ma'am, you're not audible. Not audible.
I think I should take that feedback from you all after today's session on a lighter note. Having said that, the youth of today are very much into social media, Instagram, Facebook, Twitter. I had an example of a young girl who was sitting outside in the reception, and because the wait was too long, she posted on Instagram there and then, the wait is too long, systems management needs to be improved, receptionists are curt, and very rarely do they say good things on this social media, very rarely. So you know what, sitting outside the clinic, she was writing this. So this is how swift they are. All of them are like that. So when we read some comments, we have to take it with a pinch of salt. Secondly, this helps us learning. There can be negative feedback. Negative feedback should not be brushed aside. Negative feedback should be as a learning point for us to see where our shortcomings are. And if we can improve in any way, none of us are very perfect. So having said that, this feedback has become a necessity. Now all tertiary care hospitals give a feedback form to the patient, so that, what they come to know what the patients are thinking and they can take the right steps. I think that's the way forward.
Thank you. Thank you, madam. Chaudhary sir, what other soft skill do you think would help us in improving rapport with our patients, relatives, or peers?
So I'll break up your question into 2 parts. One is rapport and the other is communication styles. I'll just tell my part of my feedback. So in terms of rapport, I think that, I have fortunately stayed and worked in many parts of the country. So my graduation was from Jipmer Pondicherry, so I can speak a bit of Tamil. I'm very familiar with the southern states. I worked in Delhi at All India Institute. Then I was in, Uttar Pradesh, Sanjay Gandhi for 25 years. Now I'm in Delhi. One of the things which I have seen is that there are a lot of people who come from uh, certain regions who are very deeply rooted in that region. For example, many of my patients, from Bihar, they would be very, very particular about which district and which village of Bihar. So, the people who come from Bangladesh, they would be making a huge amount of hair splitting as to whether it is, one of those places in Rajshahi or whether it is Chittagong. So I find that one of the opening points when it comes to rapport building is to talk a little bit about where they come from, and having to talk a little bit about that, oh, Rajshahi, that's a place which has the best mangoes in the world, and so on and so forth. So it gives them a speak to talk with pride about their place, and it gives them a sense of identity, which works very well. And the same thing I have done here in Gurgaon also, and they're pretty good. I mean, I think that's one of the styles which my grandfather used to do, who was a magistrate, and I thought that it worked wonders, giving them a sense of identity to talk about. So rapport building, that is one. The other, of course, rapport building is anything which is common. So if there is a fellow who's got a passion for football, and you nudge him a little bit as to whether the Argentinian style is better or the Brazilian style is better, So Bengalis, for example, Mohan Bagan or East Bengal, so they are very passionate. So they would take that as a very important point for rapport building, any of these methods. So I think that rapport is important. I mean, and rapport basically means that you are actually giving that person a bit of importance to express his specific identity, and you are acknowledging it with a degree of respect. So different styles work with different people. So that's it. With regard to the communication style, I think both my two predecessors talked. I'll tell you, we often think that it has to be an individual style, like Dr. Chaudhary's style. But I think the other factor is that the patient whom we are addressing, what do you think is the style that might work better with him? For example, I even now do a clinic in Lucknow, and most of my patients there are from the rural sector. So if that person has got a gallbladder stone, which is a painful stone, um, I don't beat around the bush talking about lithotripsy and this and that and all. And I tell them straight that, look, if it is symptomatic and causing pain, and you have had 2 attacks, the simplest thing is to actually get it done with, get it operated. You can choose where and when. Few good surgeons I would name, but I think you should get it done rather than just sit on it and get into a problem. Those decisions are easy. So I think that instead of being what we call as a cafeteria approach of telling them 5 options, I usually would tell them 1 or 2, unless they ask me, can there be anything else, like a medicine they know of a Unani doctor who gave medicines and the stone went off. So those would be exceptions rather than the rule. So I would treat it with a bit of not disdain, but with query concern that, let's go on the more proven track rather than something which might have occurred once in a while. And that's how I would negotiate. When it comes to certain diseases where the approaches can indeed be very different, complicated cases dealing with people who have traveled all over the world, and they have a lot of knowledge and all that, there things are a bit different. And there, I would actually play my cards straight on the table, tell them these are the divergent points of view. I would also tell them that I know that different doctors will have different points of view, but this is what I know, and this is what I think would be most appropriate given your situation right now. For example, the use of biologicals in inflammatory bowel disease. They're expensive, and they would work in about 70%. They may not work in some, they may have complications. So I think that I like to put my cards straight on the table and have them make up their mind. If they ask me what I would do, I would then offer to them what I would do if I had the resources and if I was in that miserable a state. So that's the slight difference that I wanted to say, is how the patient is likely to accept.
Thank you, sir. Ishak, sir, what care
Yeah.
should we take while communicating with media, both print and digital media? What would you say?
Yeah. Okay, print and digital media is a double-edged sword, and it helps in educating the mass population as well as misleading the population also. Nowadays, the WhatsApp messages, they are coming so much in number, and they are misguiding everybody that everybody thinks that they know everything about the disease, and they don't have any scientific basis regarding that. And the person who is receiving that, he thinks that he is doing some good work by just propagating that news to the others. And this is the worst thing which is happening because of this digital media. So what I feel is, they are more in number and doctors are less in number, but still I think we should try to use that media and that media only, and we should try to explain them where exactly the facts are. And when we are just talking to the media at that time, we should not stress more on the complications and what will happen and what are the disasters of this disease and all that. In fact, we should more concentrate on prevention, precautions, and treatment part of the disease rather than unnecessary, the fear. We are just spreading the fear among the mass population. So I think it is a very latest topic that how to control all these things. It is very difficult. I don't know, there may be some other experts in it, but we have to do something. Everybody should do something, that we should write some messages and try to control such kind of digital problems which are occurring, and we should just promote the knowledge about the diseases. Like if at all the COVID was there, at that time it was every day some new problem was coming, new treatment was coming, and everybody was following. All the population, everybody was following the things without even thinking whether it is scientific or not. Even good and well-educated people were doing all these things. So it is a question which is really problematic, and I don't know what exactly the solution is. This is the one solution which I have in front of me. So we have to just, everybody should work for it. That's all I will say. Yeah.
I suppose it's important to disseminate scientific information, so making very responsible statements when we are talking.
Yes.
Thank you, sir. Over to you, Prachi.
As it is rightly said, we learn great learnings from our past experiences. So, Sita ma'am, how your past experience with your communication style? Sita ma'am?
Ma'am, you are mute.
Yeah. So, how your past experiences shaped your communication style, ma'am?
Communication is derived from the Latin word communicare, which means share. And in medicine, we should share with care. That is the basis of good communication skill for a doctor. I have learned my personal experience by watching others. You have to think before you talk. Nothing should anger you to such an extent that you blurt out. And I have also realized if we have good non-verbal skills, verbal skills follow. So that puts the patient at ease also. Thirdly, we need to be careful about our facial expressions when we talk. We are not seeing it, but the person opposite us is seeing it. So from our great teachers, we have seen how they communicate with the patient, how they express empathy to the patient. So I have learned a lot from watching others. Besides parental influence, my father was a public figure and he had great oratory and managerial skills. So when we were small and we did something wrong, he just patted us on our back, put his hand on our back, and he said, "May you become from a good to a better girl." So that told us everything, that he was unhappy, but what we could make him happy. Just his non-verbal communication was enough to drive home the point, precise and to the point. So I've learned a lot from my father. And life experiences. My husband and I were inside Singhania Hospital when Mr. Anandige died. And the news was broken, like Dr. Chowdhury said, to a mob, and they went berserk. They broke the hospital pains. They came into the hospital. They went berserk. They set the hospital on fire. We escaped with our life. So that one experience taught us so much to Tol Mol Ke Bol. Thank you.
And I got goosebumps, ma'am. Thank you for sharing your experience. Sir, please throw some light on how to practice in a corporate setup.
Whom are you asking?
Chaudhary sir, please
You're
comment
asking
on
me,
a
yeah.
practice in a yes,
Yeah,
yes.
yeah. So I'll tell you, it's been different because I was in an academic institute for 35 years overall, AIMS and Sanjay Gandhi. Then I moved to a private hospital. So there were a few things that you have to set for yourself. And when I joined, and this was with a slight early retirement plan, I moved here for my kids. My terms were very easy. I told the management that, look, you tell me how much I think I should get or I deserve. But one thing is, you have to promise me that for the next 3 to 5 years, you're not going to ask me that am I generating enough or not? Because I would like to practice the way I do. So if you are okay with it, it's fine. If you're not, it's fine. Thank you. Now, for whatever reason, they said that we are okay with you. And then after 5 years, they said that, look, we never talked to you about money, but we want to renew your contract for another 5 years. Obviously, it meant that they were benefiting from me from whatever way. Now, the person who was second to me in terms of seniority was drawing almost double the salary that I was drawing. But the main thing I must tell you is that you shouldn't be competitive. I mean, don't look at the neighbor's lawn. I was getting what I thought I deserved. In the sense that I had one more clause. I said that I'll go on all over the country giving lectures because I'm an academician. So don't curtail me that, I'm seeing less patients and I'm giving more talks. In fact, tomorrow I have to go to Chennai for a oration. So I said, then look, that's my priority. If you are accepting it, it's fine. Otherwise, it's okay. Now, in a way, if the management is sensible, they will benefit. Because you see, when I'm going around giving so many talks and conducting sessions all over the country, it enhances their reputation. You see, after my 8 or 10 books with Fortis mentioned there, obviously it would be a stupid fellow not to realize that, that institute is also coming into the limelight. But yeah, I have set my own terms and I am not ambitious or greedy. What I am getting, I am fine. But I think that I have to be satisfied with the terms of what makes me satisfied. And I have many other things to make me satisfied rather than the usual measure that we have of how much are you earning. So that is, I think, so far as I'm concerned, with regard to most of my patients who come, I absolutely don't mind sending them off to my other people for procedures and so on and so forth, because to me at this phase of my life, money is not important. Having said that, I can't say the same for young doctors. You see, many young doctors have many other constraints, like, they have young children, the school fees have really gone up. They want a security for their house or home. And when I see my next three generation of young doctors, every time, every 3 months they come and they somehow the topic comes to, sir, could we earn more? I said, yeah, all the best. I'm sure you need to earn more, but I'm not the right person. But I do understand their expectations are high on the monetary front. So it's very difficult to have everybody on the same page. But I think that what's most important for each one of us is to know how to cut the cloth according to what you require and what makes you happy, rather than just imitating what Shah Rukh Khan is wearing.
Thank you, sir. These are very helpful points for our audience, which are in transition phase from government to corporate sectors. My last question is to Ishaq, sir. Sir, how is the practice in rural area is different from that of urban setups or corporate setups?
Yeah, I started my practice in 1995, and I had seen many phases of this practice. In the initial phase, I saw for few years that era when the doctor was considered as a god. That was a good feeling. That was not the truth. that was a good feeling that people were agreeing with whatever we were saying, and they were accepting whatever we were doing it, and they were happy with the results. And then they used to say, now we can't help it. God has just said that, nobody can help it now. So this is the era which was there in 1995 to 98, 99. That's 2 to 3 years. And now the things have changed completely. Here in rural area, doing the practice is really it is a very difficult job, because first of all, our resources are very limited, and the expectations of the patients are more. The patients are not that educated, but still you have to satisfy them. You have to just, go to their level and make them understand their feelings. And another thing is that whatever work we are doing at the rural area, that same laparoscopic cholecystectomy, which I am doing it, and that also in a very, very nice manner, the way it is done in the Mumbai. But people are ready to give more than 1 lakh rupees there, but not more than 30,000 rupees to my hospital. And my hospital is also about 100-bedded hospital, multi-specialty hospital with all the facility with PET scan, CT scan, everything is there. But still, I cannot take more money financially. The people's expectations are something different than the cities and all that. But still, I am happy that whatever I am doing in the rural area, the things, my hospital was the first hospital, multi-specialty hospital, first ICU. I started my first ICU. So I am happy that, being a doctor, I am doing something for the community and for my birthplace. So that way, I am very much satisfied with my practice. And I feel that financial, this thing is not a regret, and I'm happy for this. And I think that's all I can say. Thank you.
Yes, sir. Your knowledge is helping someone heal is the best feeling ever, and you sleep peacefully at night. That's what I feel.
Yeah.
Thank you, sir. Thank you for the great experience. Over to you, Shrutika ma'am.
Yeah, very, very stimulating discussion. And as a psychiatrist, I can say ultimately it is about the humanness in us, reaching out to a human. I think, as most of the speakers said, sometimes we forget the relation, like whether it's a client and a care provider or whatever. But ultimately, when we reach out as a human to the other, most of the problems don't occur. And in that human nature, if there is space for discussion and agreeing that sometimes things can go wrong, and when we are on the same level playing field and there is a discussion dialogue going on, most things I have said, because I educated in Mumbai, then I was in UK for 9 years, and then I'm practicing in Chiplun. But what has helped me work in a small setup like Chiplun is again, once you understand yourself better, you are able to reach out to your patients better, and agreeing that, yeah, sometimes things might not go away. Let us have a discussion, and it is okay to go to another doctor. And if the patient comes back, that is okay too. I was just going through my mind when Dr. Gaudas was saying about how in the initial phase of our practice, we get sometimes a bit uptight when our patient goes somewhere else and that ego comes in. But with time, we are able to have more humility, shall we say that, yeah, he needs the space. My communication style sometimes might not match that patient, and he is within his limits to go somewhere else. As long as he has a good outcome, we should not be objecting it, and welcoming back if he does come back. So yeah, I mean, it was a really, really good session, and I'm very thankful to all the speakers for making the time for it. I think Alpa Dalal ma'am is there today with us from UMANG. I don't think Gauri is here. So Alpa madam, would you like to say a few words? And if there are any questions also, someone wants to ask. I don't think there have been any questions, but if someone wants to ask, we do have about a few minutes for questions. Alpa madam? I was hoping Gauri could join us, but she doesn't seem to be here.
I think
Betsy madam?
President is there. I think the IMA president.
Yeah, Dr. Kute, I think, joined us. Dr. Kute, would you like to say a few words? Thank you for joining us. Thanks for giving us this forum, sir. Dr. Kute? Let's see, madam. Is Dr. Kute still with us?
Wait, I'll just check, ma'am.
Yeah. Prachi, you being the MARD representative, what would you say? How has this session helped us, all the young doctors? Because this is the typical thing. I think in medical school, often communication styles and these things, we never get any grounding on this, isn't it? And we just learn hands-on once we start seeing patients. What would you say?
Yes, ma'am. As Chaudhary sir said, whenever there is a situation or critical to deal with, we go more with the textbook thing. We start to explain in medical terms with the patient. And yeah, they are not in that psyche of understanding what's happening. So that emotional quotient we need to deal with, and that comes with experience, as sir said. So yes, this session definitely helped me, and I'm sure people of my age group to understand that it's important how you talk, and it's important to use right words and a right tone. Yes, that's it.
Yeah. I think someone wants to ask questions. Is it Dr. Rajesh Irvani? Yeah, please go ahead. We have few minutes for questions.
Yes, good evening, madam. Thanks a lot for arranging this beautiful section. Actually, I have one question that supposing in OPD you are seeing the patient, and at non-OPD hours that patient is calling up and asking for some advice, maybe on the same day or some 2 days afterwards for the same complaint or some other complaint. So how should we deal with those patients on phone if they're asking?
Geeta, madam, do you want to address that question?
Okay. What happens is it depends on what you have put forward to the patient. Generally, what I do is we have a hospital mobile number where our RMOs are always available. So we tell them that if you have any questions during non-office hours, to please call and they will address your queries. If not, if you need to speak to me, call on the landline in the hospital when I'm in the OPD so that I can talk to you. I clearly tell them that once I reach home, I may not answer the phones, because unless you draw a line, they call you at all odd times for very frivolous queries. So it depends. If right in the beginning you tell them, they accept it.
Thank you. Yeah. Betsy, madam, is Dr. Kute with us? Anybody from IMA? Santosh madam had joined initially.
No, I can't see him, ma'am. I was searching for sir. Not there.
Yeah. Okay. Anyway, it has been a very, very, very good session. And again, on behalf of UMANG and IMA, I really thank all the speakers, and thanks Prachi for helping me in this. Unless there are any more questions, I think we can bring this to a close. And thank you, sir and madam, for your wise words and your blessings. Hope this video will be continue to be watched, and UMANG will continue to do lots of such sessions, because there is a lot of need for these such sort of forums. And I really felt, even as a psychiatrist, that during our med school days, there is not enough soft skills development or communication skills workshops. So hope that UMANG and such initiatives help us all doctors to improve our communication skills and improve and that would benefit our patients. So thank you again, everyone, for being with us. And good night.
Thank you.
Thank you.
Okay,
so
thank
much.
you very much. Thank
Good
you.
night. Good.